I said the same thing about Dan, actually.
It was a
Shine.
yeah, it was salad.
I watched Sam do.
All right, you went from that corner of the table to this corner of the screen.
Oh, I have it. Okay.
Yes.
Yeah, perfect.
Explore the studio space.
Excellent.
Okay?
Let me hold on. Let me grab this.
Oh.
Let me grab some of my props then before we grab. Okay. This. Yep.
It seemed better.
Yeah, maybe there's a couple burger in the bottom. But
I'm pretty sure there's at least one.
That's good.
It's a good example.
Yeah, it's like a velociraptor.
yes.
Why is this here? This is distracting.
Turn around.
this is distracting.
But like compared to like.
We good?
We're good.
All right. Bad start. Rough start. Hey guys.
Chris.
Thanks for having me back again. I know all of you, so this is good. I can skip kind of the intro part. There's a lot of kind of meat to this presentation. So let's just get right into it. So we're going to go over the comprehensive rehab management of individuals with scoliosis due to popular request. We're going to go pretty deep into the anatomy and kind of like pathogenesis of this condition first before we go into more like everyday management of it. If you have any questions at any point, ask me as we go. That being said, some of these things, I promise, there's going to be a few slides you're going to be like, I don't know if that makes sense, and then the next slide, it will make sense. So give me a little bit of time. You know me. This is the same slide as last time. We're going to skip. I did get critiques that the picture with me and Christy was too small, so I made it smaller. So if you really squint, you can see her a little bit. So we're going to get right into this. Same as last time, I have nothing to disclose. I'm doing this in exchange for a very generous charitable donation to Tap Cancer Out, which is a charity that donates all funds to different subsidiaries that are responsible for cancer research, assistance with patients, things like that. I personally am involved with this charity organization. It's called Tap Cancer Out. It's a Brazilian Jiu-Jitsu based charity. Basically, once a year, we do a hour-long, like, kind of like sparring match with a partner, and we just raise a whole bunch of money in the meantime. So let's talk about scoliosis first.
All right, today we're going to use gym class to test you for scoliosis.
What is scoliosis?
I will not explain that. Krista Cesare, who's only ever treated you guys for headaches, is going to take you to the bathroom stall, have you take your shorts off, and then if she does find scoliosis, that's on you to tell your parents.
If they find out we have it, what do we do?
Yeah, is there any like follow-up?
Nope, no, you're never going to hear anything about this ever again.
Why doesn't our doctor do this?
Only school nurses are qualified to check for scoliosis.
I feel like my doctor could easily take 30 seconds out of my physical and check for a curve.
This is the one thing that school nurses have. Let's let them have this. And then once you're done being checked for your potentially debilitating spine disorder, we will resume our archery unit.
Down, then. You got it.
What's that mean for me?
I don't know.
So I feel like that sums up with a lot of scoliosis checks were like for us.
That was really well done.
So
That was really well done.
I thought that was like perfect. So just to give you, I should introduce one more piece of background that wasn't included in my introduction. About a year and a half ago, I did a quote scoliosis intensive. So it was about a 48-hour in-person course where we focused basically on the management of individuals with scoliosis. It was based primarily on adolescents because that is the largest population you guys will also see in the clinic with this condition. But from then on, I became one of our like scoliosis go-to people at LVHN. And since then, my schedule is now composed of about 20 to 30% individuals who have scoliosis, so it's a pretty large portion of my schedule at this point. So some of these things are going to be based off of quite a bit of studies that I will have backed up. Some of them are just based more on clinical observations. We can chat about that as we go. All right?
All right, today we're going to...
So first of all, let's just go through what normal spinal curvatures are. So normal, quote, spinal curves really only occur in the sagittal plane. We all should know this. They occur in the cervical, thoracic, and lumbar regions. I was really sad that we don't have a student here today because these are kind of perfect student questions to ask. But But essentially, the purpose of these normal spinal curves are just to serve as essentially shock absorbers. So they distribute the mechanical stress of your body throughout all day-to-day functions and recreational activities. And they just keep your head positioned over the pelvis, relatively speaking, which is really important for more dynamic balance related purposes. Normative values are in your cervical spine, you're going to have normal lordosis between 20 to 40 degrees. Thoracic spine is going to be 20 to 50 degrees of kyphosis. And then the lumbar spine is 40 to 60 degrees of lordosis. And ultimately speaking, in normative values, you are going to have like a balanced spinal shape when you bring all those together. And again, usually these curvatures are only really normal. I'm going to keep using air quotes about that. In the sagittal plane, you really shouldn't have much deviation side by side in like frontal plane, especially not rotational plane. There are a number of sagittal plane deformities. Now you're going to see me use a lot of like quotes around these. A lot of research in scoliosis is actually based off of quite a bit of European research. I don't know why, but this is an area where a lot of European research has been pushed ahead quite a bit more than United States research. And just some of the verbiage they use, I think some individuals would take issues with. Like there's still a lot of terminology like deformity and things like that. So I try not to use that terminology. If I accidentally do, please call me out. We can kind of talk about that a little bit because it does make a big difference, especially if you guys have been to my chronic pain talk. Like the words you use actually matter quite a bit. So sometimes I am going to quote some of these organizations, but please don't take that as me just like taking shots or something like that. If I take shots, you'll know. And then there are a number of these sagittal plane deformities, such as Schorman's, which basically is a fancy way of saying a hyperkyphosis of the thoracic spine, and thoracic lordosis, or quote, inverted back. And then there's others, but for this, we're not really going to get involved with that because those are not technically scoliosis conditions. So, what is scoliosis? This actually was like, I felt really dumb when I went to this course because I was already a PT for like, I guess 6 or 7 years when I went to this. And they're like, what is scoliosis? And everyone's like, oh, it's a lateral deviation of your spine. And they're like, no. I was like, what do you mean, no? Scoliosis is a 3-dimensional, quote, deformity. So it is not just a lateral curvature of your spine. This curvature occurs in all 3 planes of motion. We're going to use our lovely spine model to kind of show exactly how that happens. But from the beginning, don't think of scoliosis just as a lateral curvature of the spine. To get that lateral curvature, there needs to be rotation both in the rotational plane, so looking from above, as well as some deviation in the frontal plane, in the sagittal plane, to make that happen. So it is a 3D deformity of the spine and trunk involving the abnormal lateral curvature, in addition to axial rotation and disturbance of the normal curvatures in the sagittal plane that we just talked about. Okay? And for scoliosis, we're going to go into what Cobb angle actually means. But to actually be diagnosed with scoliosis officially, your Cobb angle has to be at least 10 degrees in the frontal plane. There's a lot of deviation among spines. There's going to be a lot of individuals who have between like 2 to 6 degrees of different curves, like totally incidental findings. Those individuals technically should not be diagnosed with scoliosis, at least based off like the formal definition of that. Okay. And then again, there is a structural scoliosis. That's going to be the basis of what we talk about in this course. And a structural scoliosis is basically scoliosis, is what you would imagine. Whereas a functional scoliosis does occur. This can occur after trauma, this can occur after injury. Sometimes it occurs due to like severe paraspinal tonicity. But these are things, generally speaking, that have a cause that's typically addressable. And when that cause is addressed, this scoliosis usually alleviates or is restored. Whereas that is not the case with structural scoliosis. So we'll go a little bit more into that, but most of the guidelines that we are going to be talking about are going to be talking more about this structural scoliosis versus functional scoliosis. And then what does scoliosis look like? I would say with most moderate to severe degrees of scoliosis, it's one of those, you'll know it when you see it. Most of the common things that you see, you'll see some, can you see my mouse on here? No, you can, okay. So you can see some uneven shoulders. With this is not the best way to do it. We know that with dominant arms versus non-dominant arms, you are going to have one shoulder that's typically elevated, but it is a pattern that you will see. you'll see winging or asymmetrical scapulae. You might see it unilaterally, and you'll actually, the vast majority of times you will see it unilaterally depending on the convexity of the curve, or you might see it bilaterally. You're going to see a misalignment of the head and the pelvis, so you're going to see a little bit of a frontal plane shift. You're going to see the elevated or depressed hip, so you'll see the little hip drops side by side. You'll see any type of lean, so this frontal plane imbalance, and then you might see a leg length discrepancy, usually an apparent leg length discrepancy. So an individual who, if you're actually measuring it and getting them all stable, it's not really a leg length discrepancy, it just looks like it is based off of all the shifts going on. So this is a typical presentation. Usually, to be honest, and we're going to go into some more, we're all going to look at each other's posture using some different outcome measures. Usually these are like occurring in groups. So if someone does have scoliosis, it's rare that you'll see like just winging or asymmetric scapulae without any type of additional compensations. And that's just kind of how the physics of the condition works. And again, we'll get into that a little bit. So this is kind of meaty part of the presentation. So with scoliosis, we said already that it is a three-dimensional, quote, deformity, okay? So this is not just a lateral, you're not just, oh God, I'm gonna break this spine. You're not just taking a vertebrae and pushing it this way. That's not what's happening, okay? Anytime there is a curvature, it's, so I kind of take this out, but then it's all gonna fall apart. We'll use this later. So with that, let's use the pictures and we'll pass that around and look at it later. So with scoliosis, okay, I'm gonna go back and forth between this picture just so you can kind of see, okay? The vertebrae and the spinous processes around the major curve, so around the primary curve of the scoliosis. The major curve is the primary one. So even if there is an S curve, you'll usually refer to the larger curve as the major curve, okay? So around the major curve, you are going to see on the concave side that the ribs are going to get really close together. And then on the convex side, the ribs are going to flare out a little bit, okay? With that as well, as they rotate, the spinous processes on each vertebrae involved with the curve are going to rotate more to the concave side, okay? So if we're, let's go back to this. Just so we're clear, convex side, concave side. Everyone got that? Okay, concave side, convex side. So as they rotate, the spinous processes will deviate more and more towards the concave side, and then the ribs follow that. So on the concave side, the ribs basically get really tight, really compressed, and then on the opposite side, they kind of flare open. And then likewise, on the convex side, the posterior aspects of the ribs start pushing posteriorly. So this is where you'll see the rib hump that a lot of individuals with scoliosis have. The rib hump is now called a thoracic prominence, or T-prom. So it's really funny when people are like, show me your T-pom. But yeah, either way. So the quote, rib hump or the thoracic prominence is usually caused because of that rotation causing the ribs to come out to the side. And then likewise, the anterior ribs on the concave side are pushed forward. So you'll typically see on the convex side, you'll see a rib hump. On the concave, a rib hump posteriorly. On the concave side, you'll see a rib hump anteriorly, and vice versa. On the convex side, you'll usually see a depression of the ribs anteriorly, and a depression of the ribs posteriorly on the opposite side. Does that make sense? I practice saying that a lot because saying convex and concave 1,000 times gets really confusing, but does that all kind of add up? Okay. So this is important to know because a lot of treatment for individuals with scoliosis is still more of your like standard contemporary physical therapy management, which can include manual therapy, mobilizations to an extent, things like that. And it's really important to know how the vertebral processes are aligned and how the vertebrae itself is aligned, because it does change the mechanics of what you're doing. And some performance of those activities, whether we're talking manual therapy or exercise interventions, can be causing undue compression on those areas, which is something you want to avoid with a little asterisk. So like a lot of extension biased activities are generally not the way to go for most individuals with scoliosis. Again, we'll get into that. Okay. The thing that we're going to discuss next, because this is a question that I get asked by pretty much every single kid and every single parent I see with scoliosis. It's like, what causes scoliosis? And it is a combination of we still don't fully know, but it's also a very complex answer because there's a lot of different things that can influence it. The most commonly cited reason why it progresses is due to this RASO phenomenon, relative anterior spinal overgrowth. So as we discussed, everything kind of looks different. It's more compressed on the concave side, more open on the convex side. Likewise, on the concave side, okay, the vertebrae and the intervertebral disc, as you can kind of see there, they become decreased in height, okay? As a result, the other side, like we think of that jelly donut stupid comparison that everyone talks about with disc, which is bogus, but anyway, the same idea, like it kind of opens up on the other side. When that happens, over time, you're looking at the unusual growth of the anterior aspect of the spine, and this growth is actually an ossification, so that the front part of the vertebrae will actually ossify and get thicker and taller versus the posterior aspect. So you start getting this like wedge-shaped vertebrae. And this is something that is it's a permanent effect. It's bone growth.
Because you said that wedge is in two different planes then?
Yes.
Frontal and sagittal.
Yes.
Okay.
Sorry. Yep. Mm-hmm. So it's occurring in the ossification is occurring in the frontal area. Good question. It's the frontal aspect of the vertebrae,
Yeah.
not necessarily in the sagittal plane. It's wherever the vertebrae is rotated towards. If you just look at
So like anterolateral.
anterior,
Okay.
I'm sorry, yeah.
Anterolateral.
So, great question. The anterior aspect of the vertebrae,
Yeah.
no matter if it's turned this way, that way, generally speaking, in the curve, will be increased in height because of this ossification compared to the dorsal aspect, where you'll actually see a compression of like the pedicles and lamina and things like that.
You were saying convex versus concave side as
Yep.
well?
So it's going to happen more on the
So like anterolateral to the concave. Concave. Yeah.
I need a better way to do this. So, this is. Can someone hold this? This raptor spine. Thank you. Can you just stand like that?
Bangkok can hold it.
Let's go over here.
Okay. So, with a thank you very much. With a right thoracic prominence, okay, you are going to see this shift, and likewise, the spinous processes here are going to rotate towards the concave side, okay? It usually doesn't move this easily, but just bear with me here, okay? While this is occurring, so we have the spinous processes there getting really kind of compressed. This is opening up. The ribs on this side are starting to get a little bit farther apart just because of the stretching aspect, and here they're getting more compressed, okay? When this is happening over time, you can even see the little like gapping between the vertebral bodies and the intervertebral discs. Over time, whether it's because of like Wolff's law and adaptation because of constant like kind of like micro movements back and forth, or because it's literally trying to fill in the space and protect the spinal cord, which is really cool, because the spinal cord is relatively quite a bit shorter than your spinal canal. So basically this space is going to fill in with bone. So it is the anterior aspect of the disc, even though it looks like it's the anterior aspect of the vertebral body, even though it's the lateral part of the spine. That's a great question. Does that make more sense? Is that clear? Okay. You got it, right, Luke? You felt everything I did on you. Thank you.
I'll have to watch that back.
So yeah, basically, and the gist of that is, if you were to like just take a pure measurement of like all the of all the vertebral bodies and intervertebral disc from an anterior versus posterior portion, individuals with scoliosis will have quite a bit longer anterior portion versus posterior portion. And that leads to this. This is, quote, the vicious cycle of scoliosis. So if you want to start here, for some reason, I don't know why, you get a spine curvature. Just like with everything else, that spine curvature will cause asymmetric loading basically with every movement that you do. Doesn't matter if you're thinking of it or not. And then that asymmetric loading, just based off of the foundational laws of physiology, you'll get a lot of asymmetric growth in various parts of your body, not just the spine, but in various parts of your body. And then with this asymmetric growth, the wedging of the intervertebral disc and the vertebrae occurs because they're trying to essentially fill in the space that should be covered. And then you get more of spinal curvature because the space is occurring, it's trying to wedge, and then there's more space on the one side, and then it keeps trying to fill. So this whole cycle is the current thought process of just how it continues to progress. Again, the underlying cause, there's not like, for at least for the idiopathic scoliosis, there's not a great reason, otherwise it would not be called idiopathic scoliosis. There are a number of other cases of scoliosis that we're going to get into in just a second, but this is actually a picture that I sometimes will reference to patients who like are really, really into it, especially parents. I don't show kids a picture labeled vicious cycle of scoliosis. But sometimes I will just use this to describe it, especially when I have adults who are very like engineer-minded and things like that, just to kind of get their heads around it. That's basically the hardest part of the presentation. Are we good? Good, okay. So there's different types of scoliosis. The vast majority of scoliosis that you're going to see, more than 75 to 80% of it, is going to be idiopathic in nature. That's, again, what we're going to be spending most of our time talking about. Idiopathic, meaning we're not fully sure what happened. 10% will be congenital. That occurs while the child is in the womb. 5 to 7% is going to be neurological. Issues like cerebral palsy, multiple sclerosis, things like that. 2 to 3% will be Recklinghausen, which is neurofibromatosis type 1. It's a really awful condition where essentially you have tumors that grow along different nervous tracts throughout your body. So you'll basically see these like nerve-based tumors. And because of that, you'll see a lot of issues with development with spinal curvatures, things like that. We're not really going to talk about things like that. There's quite a bit of difference in management with things like that, but I will be mentioning that as we kind of go on. And then there's other various conditions, tumors that are not along neurological tracts, Marfan's disease, Beals, things like that. There's a lot of other like small things you may see along the way. And then there's also, it's not on here, usually it falls under idiopathic, although it's not technically idiopathic. A lot of older patients that you'll see, they'll be referred with like, quote, degenerative scoliosis. And it is, as it sounds, a lot of times it will be caused because of like breakdown, typically in the lumbar spine, as in a combination of aging, inactivity, sedentary lifestyles, things like that kind of contributes to that over the years. So you may get referrals for like adult onset scoliosis, or you may get referrals for something called degenerative scoliosis. And that's just typically what you're looking at. And again, most of those, the vast majority occur in the lumbar spine and then the thoracic spine after that. Okay. So we're going to briefly just mention congenital scoliosis. So this happens because of abnormal vertebral development during the gestation cycle. This actually occurs in every 10,000 newborns. There's usually one that has something like this. Most are actually fairly mild and resolve over time. And some you actually may not even realize they have until they are an adolescent because the issues are so mild and because of like scanning not really picking it up. And usually it happens because of one of two things. You'll either get an incomplete formation of the vertebrae in the spine. So you'll get something what's called a hemivertebrae, which is, sorry, it's kind of hard to see that right here, but that's right there. So it's when a vertebrae doesn't fully form and you basically have a partial vertebrae. It creates this really sharp angle in the spine. It can get worse over time. Interestingly enough, sometimes you'll actually have two hemivertebrae, and this occurs fairly commonly, and they balance each other out. It's kind of like the spine's attempt to like figure things out. So again, you may have individuals who have these, and I think we've all like might have seen, like I definitely had one who had like an x-ray like when I was like a year out of school, and I was like, what the heck is that? And it was like a 24-year-old who had it, and they had 2, no issues at all, but they just balanced each other out. It just became a cool party trick for them. Like, oh look, I have 2 little baby vertebrae. But again, one can cause issues over time.
Chris, is it an extra vertebrae or is it a poorly formed?
Usually it's a poorly formed one. You can have an extra vertebrae.
L3.
Yes, you can have an extra vertebrae. That can occur. Typically, it's a poorly formed one. Or, I was going a little bit more into the research with this. I think it's still like, if it's one poorly formed one or one that's like too aggressively formed on top, and then it sometimes like takes over the space. But regardless, it usually replaces, but it can be an extra one. And then you also have the failure of separation of vertebrae, and this is basically so going into the gestation cycle. Usually your spine forms as one complete column, and then it kind of goes into individual vertebrae over time. And sometimes it doesn't fully separate into segments, so you may have this partial fusion that occurs in various aspects of the spine. You'll sometimes see it on an X-ray referred to as like a bony bar, and that's exactly what it looks like. It just looks like a piece of bone going up, usually just like this picture shows, usually like one unilateral aspect of the spine. So, because that happens, typically you'll see the curvature just progress over time. And then a lot of times it does happen where a combination of these can occur. So you're looking at some areas of the spine may have a hemivertebrae, some may have a partially fused vertebrae, and then there's a lot of different developmental conditions that I am not an expert in at all that may be causing that. So you'll sometimes see other like neurological conditions, potentially cognitive issues, things like that. Not always, but sometimes. All right. And then another subset of scoliosis that you will see quite a bit is neurological scoliosis. So this is more from the lack of muscle control or the increase in spasticity in trunk muscles over time. And it essentially causes a curve because of these soft tissue abnormalities, but over time you will see structural scoliosis occur for those same things that we discussed in the vicious cycle, because the curvature is there, whether it's because of soft tissue or not, but then you have bony changes, you have adaptations with posture, you have adaptations basically that occur along the chain. So you will see, like, this is actually a really neat chart that shows like the etiology of scoliosis in different individuals with neurological conditions. So if you have individuals with Friedreich's ataxia, for example, which is usually like you'll see young individuals with this condition. There's a lot of times, 80% chance that there's scoliosis associated with it. Individuals with cerebral palsy, you'll see scoliosis there. The biggest thing from our end is we're going to talk about when things like bracing and surgery are recommended. With neurological scoliosis, there's very, very limited research that suggests that it helps prevent the progression of the curve. Because even when they are braced, the tonicity is usually still there, the muscle changes are usually still there. So there's very limited research, if any, that it helps slow progression of the curvature. Some people may have it from a comfort perspective. It might make them feel better, which is a great reason to have it. But if you're looking to say, like, we need to stop the progression, it's not the best thing to do with this type of population. So just keeping that in mind, because with other types of scoliosis, especially idiopathic, there is a very appropriate time and place to recommend bracing.
So even if somebody has a brace for more comfort levels, would you recommend them not? Would you just recommend them wearing it, or try to get them out of it? Just to work on their own muscular.
Great question.
Or a little bit of both.
A little bit of both. So if it's somebody who has the independent ability to work on it like on their own, and they can sustain the postural corrections. Like I have a guy who's 40, early 40s with CP, who everything I tell him to do, he can like absolutely correct on his own. He's very, very compliant with therapy. So he doesn't use, other than a brace for like his dorsiflexion, he doesn't use any type of trunk bracing. He does have scoliosis, but he's somebody who we use a lot of active treatment for. I have another individual who's 20 who has CP, also has severe scoliosis. He's somebody we brace for because he also has significant cognitive impairments. So the education that we provide in terms of positioning and general active movements aren't really sticking. So definitely something you can still utilize. But I think just like with all bracing, you want to try to avoid sticking somebody in a brace for their entire life if you can help it. But there are, with the cognitive challenges associated with a number of these conditions, or I shouldn't even say that, there's other individuals who just have the physical inability to do so. Like somebody who has a severe SCI or something like that. Then you would use a brace to help correct it, because no amount of telling them to, just shift your pelvis, you're gonna be like, can't do that. So yeah, I say if you have the physical and cognitive ability, you should be encouraging the active approach.
Yeah.
Otherwise, it might be a good idea to utilize the brace and then spend your efforts doing something more productive with your time.
Sure.
Great question. Good. All right, now the fun stuff. So idiopathic scoliosis. Again, it's called idiopathic because there's no other underlying disease that's identified. You can get scoliosis at any age. There are 3 major periods that it occurs that we'll go into, that it's more common to occur, that we'll get into. But the vast majority are detected between the ages of 10 and 18 because of videos like we saw before, because that's when they do a lot of screening, and then you get what do you do about it? I don't know. Go see your physician. But it is the quote, the most common pediatric deformity of the spine. Okay. And we already talked about this. It is a 3-dimensional curvature, but it's not just a lateral curvature. Prevalence. It's funny because it's simultaneously very common in like from a percentage scale, but like the amount of people, and I think this is, can I put Sam on the spot here? Like Katie and I are both married to people with scoliosis who don't really have like symptoms to it. So as a result, you're like, oh, everybody must have scoliosis. But this is falling. The individuals with a greater than 10-degree curve in the population are only about 2 to 3%. Individuals with more than 20 degrees are about 0.3 to 0.5%. And individuals with 40 degrees, which is typically when you're looking at potential surgical intervention, is less than 0.1% of the population. The female to male ratio, essentially females do have a higher chance of being diagnosed with scoliosis, and the greater the higher the curve, the higher percent that are women. So there's different thoughts because of leptin levels, different hormones, the same things that are associated with every condition that happens like this. But that's kind of where the research is right now. When you get referrals for scoliosis, or when you're making a diagnosis of scoliosis, there are essentially 3 big things you need to look at. The first is the topography, so where the scoliosis actually occurs. The hardest part with scoliosis is when you get referrals from physicians who mean well but just aren't very familiar with scoliosis, and you'll just get like a referral that says, patient has scoliosis. Shit. Like you don't have x-rays in front of you, don't have anything so you just have to really like try to define. But thankfully we've, over the past like year and a half at our company, we've done a much better job of having like radiologists and pediatricians kind of get in touch with the lingo. So now we'll get like very specific referrals, which just saves you a little bit of time in terms of what you're looking for. You're still doing full screens, it's not changing anything, but it's nice walking into a room and having an idea of what to look for. So you're going to have your classic cervical, thoracic, and lumbar, but you'll also see indications for cervicothoracic, which occurs from C7 to T1, as well as thoracolumbar, T12 through L1. So part of the naming scheme is just indicating where the scoliosis occurs. This is a more important one for me, because again, like we all have eyes. Like we can figure out where the location of the curve is. It's really important to know when they were diagnosed with scoliosis. So the longer the period between the diagnosis of scoliosis and the completion of a child's growth, basically the greater the risk of developing a more severe curvature. So the younger they are diagnosed, typically the more concerned you are about the severity of progression. It doesn't mean they will progress to a severe level, but the recommendations typically will change over time. This is basically the naming scheme for infantile, juvenile, adolescent, or adult. Again, the vast majority are identified during adolescence. I'm treating somebody right now who's 7 who has juvenile, and she has a scoliosis of like 11 degrees, which just meets the curve. So I see her once every 2 weeks, and I'm seeing her for like 4 sessions, just to like give her like basic exercises and things like that. But then there are periods of onset where kids are a little bit more susceptible to being diagnosed or being or having development into scoliosis. It's the 0 to 3 year period, the 5 to 8 year period, and then the 10 to whenever they're done growing period, which is a very big period. But those are usually the periods where you're looking for potential peak onset. And then the final part of the naming scheme is the degree of scoliosis. This is also hugely important, especially from a direct access standpoint, because this is going to help make a lot of recommendations about their treatment in the future. So when we're done this, I'm going to fast forward a little bit. You guys are going to get 3 attachments in an email from me, and then 1 slide that's going to be probably the most important slide you will ever have for scoliosis, because I use it literally all the time. So we'll leaving a little bit of suspense there. But typically with Cobb angles, low is below 20 degrees, moderate is 21 to 35 degrees. You typically don't usually see, at least in the States, you usually don't see these types of like moderate to severe. A lot of times in the States you'll see severe as 36 plus, but you will see different degrees there. But generally speaking, there's low, moderate, severe scoliosis, and all those have their own recommendations associated with it. So let's talk about the Cobb angle for a little bit, because the Cobb angle is going to determine, again, a lot of your treatment strategies and what to do from there. We already talked about the younger the diagnosis and the greater the gap between diagnosis and finishing development, the higher the risk there is of further progression of the condition. But likewise, if there are certain, quote, critical angles that occur, and these are where a lot of the research says that individuals may be facing additional issues later in life, such as their decreased quality of life, aesthetic challenges, pain, and then progressive functional limitations. So this is usually in the 30 to 50 degree area with scoliosis, regardless of age. And that's why recommendations will change with those individuals. With a Cobb angle, the measurement angle, as long as you are looking at it on a radiograph and assuming that the person did it is qualified, there's typically a measurement error of about 5 degrees, which is a lot, but it doesn't usually change too many recommendations, and usually you will have repeated x-rays over time. And then over 30 degrees, like I said, the risk of progression increases, and then over 50, it's like very, like, it's almost positive that it will continue to progress, and this is why surgical intervention is usually warranted. So a Cobb angle is something that is very easy to measure. It's very easy to mess up as well. It's a very, very easy thing to measure. If you have their radiograph, what you are going to do is you are going to look at the curve, okay? You're going to find the curve on the radiograph. You are basically going to trace the curve. You're going to find the uppermost aspect of the curve, okay? And actually, let me show you on, I think I have a better, yeah, I do. So you're going to draw a line along the vertebrae at the very top of the curve, and you identify the top of the curve as when the spine changes orientation. So the curve is going to go up, and it's going to look like this in like a half moon, and then there's going to be one vertebrae that changes the angle. Okay, you're going to go to the vertebrae right before the one that changes the angle, and that's going to be the top part of your curve. And you're going to use the top of that vertebrae. Then you're going to do the same thing with the bottom part. You're going to use the bottom end plate. So top end plate, upper end plate of the top vertebrae, bottom end plate of the lower vertebrae. All right. And then if I go back here, you're just basically going to draw a line between them. There's 2 easy ways to do it. If you have all the space in the world, usually radiographs are really large. So if you have all the space in the world, you can just bisect the lines, and then that's your Cobb angle. Almost always, you have to use a little bit of math, and you have to basically get the same lines from them, and then you basically just bisect them with one perpendicular line. This is like basic geometry that I totally forgot when I went to this course. So you can just use that, because whatever this angle is going to equal, this angle is going to equal. So on my, like, if I have an individual scoliosis and it's on my screen, I literally just make the radiograph really small and then I just draw my angles, and I'm like, oh, there it is. But if you have the large picture and you don't want to just keep drawing out, you can use it like this. So it does happen where like you might have to, hopefully it's not during your session. I've never done it during a session, but I have had individuals who like, again, I've gotten a referral for scoliosis, and I had an x-ray, and I was like, I have no idea what I'm looking at. So let me just see what the angle is here. So I'm not gonna spend a lot of time on that, but it is a nice skill to have. And then on the x-ray, if you see something called the apical vertebrae, that is the vertebrae with the greatest degree of rotation. So it's usually the site where the biggest curve, the tip of the curve occurs. Okay. And then the other thing that is important when you look at x-rays or when you get referrals, you will be looking at typically everywhere. When I've gotten referrals from St. Luke's and LVHN, they usually include this. I'm not sure if more Philly-based health systems use this or another very similar scale. But this is the Risser scale. It's used to grade skeletal maturity, and it looks at basically the level of ossification and the fusion of the iliac crest. And again, there's differences in US versus Euro. I want to say in European scales, it actually only goes up to stage 4 because they feel like they can never determine if it is stage 5. US, they usually have a stage 5. But basically, long story short, stage 0 means complete skeletal immaturity. There's still a lot of potential for growth. Stage 4 or 5 means that the child is essentially skeletally mature, where they might still continue to grow from a height perspective and like a build perspective, but they're usually not going to have any major growth spurts after that. This usually does align with puberty, but puberty is when you will see the start of the change of stages, but it might take a long time for them to actually hit stage 4. Like I'm treating a 17-year-old who's still stage 3, which I'm like, whoa, I didn't know that's possible. And then you'll see it it's kind of tough to see on this. You'll see that there's a very thick black line right here in the iliac crest. That just indicates skeletal immaturity. Over time, that basically fuses, so it should just look like a clean white line. So if you see this black line, it usually means that they're not skeletally mature. So again, I promise I'm not just tossing random things at you for recommendations. This is another thing in addition to Cobb angle and age that makes a big difference over time. This is the same thing we just talked about. The younger and more skeletally immature the patient, there's a higher curve of, the younger and more skeletally immature the patient, as well as the higher the degree of the curve, just means that they have a higher risk of progression of that curvature. In a lot of different studies, you'll kind of see this equation used to talk about the risk of progression over time. I think this is pretty useful early on when you're specifically treating individuals for scoliosis, just so you can kind of get ideas in your head and staging in your head. But I definitely would not do this for every patient. I definitely would not bring this up to every patient. But it does help you kind of figure out the degree of treatment that you're going to be using. And then differences between levoscoliosis, so a convexity on the left side, versus dextroscoliosis, a convexity on the right side. This is a study, and there is a big part of this in my course that broke my brain, and it still breaks my brain. So the vast majority of individuals with idiopathic adolescent scoliosis will have a right convexity in their thoracic spine. I want to say, I'm on video so you can quote me, but I think it's 10% that might have a levoscoliosis. There have been studies that look at the individuals who have the levoscoliosis, and there is a scary high percentage of individuals with a levoscoliosis that also have some form of quote neural abnormality, such as a Chiari malformation, a syringomyelia, something involving the right where the cerebellum is. A lot of these individuals actually don't have any signs or symptoms associated with the neurological abnormality. A lot of times it's found as they do the x-ray and they're like, oh, that's interesting. But there is some recommendation that if you do have an individual with a levoscoliosis, we should be doing this, everybody, but just spend a little bit more time doing your neurological screens. Like, don't blow them off if they're like complaining a little bit more of like coordination-based issues, especially if you have a young kid. It's something to just consider. So again, this is something where I talk to some of my colleagues as well who were like who see quite a bit of scoliosis, and like I see a few individuals with left-sided, and I don't see anything atypical. But the research is out there, so it's just something to keep in mind over time. But like, don't freak out and think anytime you get a kid with a left-sided curve like it's a red flag. But it is something that you should be doing due diligence and making sure that you're monitoring. We're not going to spend time doing this. This is just an example of different ways you will see curves presented. The radiological ones on the left are basically how you will get, how you will see curves presented on X-rays or with referrals, and they're very descriptive, like based on the title. So a single major high thoracic curve. It is a single curve. It is a big curve, and it's in the high thoracic region, so the upper thoracic region. You might see a major thoracic curve and a minor lumbar curve, so you might see an S-shaped curvature. But a major and a minor means that the curve is not the same, so it is an imbalanced curvature. You might see a double major thoracic, which is just a pure S-curve in the thoracic spine. You might see combinations of this. But these are typically like the ways that they'll be written out when you get them. There are different organizations out there. One is called BSPTS. They are popular for the Rigo method of scoliosis treatment, which is like an offshoot of Schroth. And they have come up with their own curvature naming style that, if you understand the naming, it really does tell you a lot, but the naming makes no sense. That's just in my opinion. But so like if you see a 3C, and these are the ones on the right, a 3C is like it's a major thoracic curve with a very small or no lumbar curve, and the pelvis on a radiology report is balanced. Whereas a 3 like CP is the same thing, but the pelvis is unbalanced. I have never seen these written in any reports I've received in the States, but again, they are increasing in popularity, and I'm gonna blame myself for just not having enough knowledge about them to maybe use them more. But there is recommendations that like it's going to be a better clinical presentation because these different naming schemes take into account how the pelvis looks. But that's pretty much that. So we talked about in Europe and America, there's a lot of different research going on. SOSORT, which is the International Society on Scoliosis, Orthopedic, and Rehab Treatment, is an international, it's a nonprofit organization, and they are all about non-operative management of scoliosis. Their recommendations are one of the biggest guidelines that providers in America and Europe use. The Scoliosis Research Society, the SRS, is a big one based in America. But for today, we're going to primarily look at SOSORT's recommendations, as that's more of a widespread. And the recommendations are very, very similar. So this is the article that I will provide you guys. All right. So we're going to kind of get a little bit into more conservative treatment. You guys doing okay? I know I'm talking a lot,
break?
but
Like, sorry, you need a break?
Yeah, you need a break? Yeah. Let's take a break. Sorry, I know it's very content heavy, but I feel like it's important to understand